We have seen in detail about the tubal pregnancy in our previous two videos. Now in this video we will see about the other types of ectopic pregnancies, in which first we will see about the pregnancy in rudimentary horn of uterus. So normally during the development of uterus, the uterus develops as two horns and then it fuses. But in some conditions there will be only one developed horn, whereas the other horn remains rudimentary. So this ectopic pregnancy develops in that rudimentary horn of the uterus. So here some of the features of the pregnancy in rudimentary horn of uterus are: there will also be formation of false decidua in the uterine cavity proper. The uterine size increases but since the muscular tissue of the horn is not well developed, because of the enlarging ovum, after a certain extent it ruptures. This can occur any time within the first 16 weeks of pregnancy. Coming to the diagnosis, diagnosis is little difficult in this condition. The points favoring diagnosis are presence of a pulsating mass which corresponds to the size of which corresponds to the duration of pregnancy, which is seen in the enlarging uterus. In these cases there will be suspicion of pregnancy in the rudimentary horn of the uterus. The treatment for this is nothing but removing the rudimentary horn of the uterus where the fertilized embryo has implanted, and if possible conserving the body of the uterus if possible. So this is the diagnosis, features and treatment of pregnancy in a rudimentary uterine horn. Next let us see about the abdominal pregnancy. Abdominal pregnancy can be either due to primary implantation of the fertilized ovum on the peritoneum, but it is most commonly due to early rupture of tubal pregnancy into the peritoneal cavity, which is nothing but secondary abdominal pregnancy. This is the most common cause. The primary abdominal pregnancy is diagnosed by a criteria called as Studiford's criteria, which says that there should be presence of normal tubes and ovaries with no evidence of recent or past pregnancies, and there should not be any evidence of uteroplacental fistula and the presence of pregnancy which is exclusively limited to the peritoneal surface. This is the Studiford's criteria to term it as primary abdominal pregnancy. Coming to the clinical features, because it is most commonly due to secondary abdominal pregnancy, there will be a history of tubal pregnancy. The symptoms suggestive of tubal pregnancy. And the other symptoms include nausea, vomiting, constipation or diarrhea, abdominal pain, and in late pregnancy there can be perception of fetal movements, but the point to be noted is the false contractions, which are the Braxton Hicks contractions, are absent in this case. And on pelvic examination, the cervix is usually displaced. Next is the diagnosis. For diagnosis, the important is ultrasound abdomen, which shows empty uterus without any gestational sac, and the uterus may be seen as separate mass in relation to the gestational sac. Then there will be absence of myometrial tissue, between the urinary bladder and the gestational sac. Coming to the X-ray examination, which shows a fetus in transverse or oblique lie, in an unusual attitude and location. These are all the points for diagnosis. Coming to the treatment, surgery is the only treatment for an abdominal pregnancy. So next is the ovarian pregnancy. The ovarian pregnancy is very rare, and here there is no decidual reaction in the uterus. And for the diagnosis of ovarian pregnancy, there is a criteria called as Spiegelberg's criteria, which says that the fallopian tube on the affected side must be normal, that is intact. Then the gestational sac should be present in the ovary, and there should be no separate ovary on the affected site. Then the gestational sac should be connected to the uterus by the ovarian ligament, and on histological examination it should reveal the presence of definite ovarian tissue in the wall of gestational sac. These are all the criteria, that is Spiegelberg's criteria for diagnosis of ovarian pregnancy, and this is done during laparotomy. Next is the cervical pregnancy. This was initially rare, but nowadays there is increase in incidence of cervical pregnancy due to increased assisted reproductive techniques. Here the endocervix is eroded by trophoblast, and there will be painless vaginal bleeding. Diagnosis is by the ultrasound abdomen, where the uterus is empty with the absence of gestational sac, and the sac is seen in cervical canal. And the treatment is usually surgical. And here for the diagnosis of cervical pregnancy, there is a criteria called as Rubin's criteria. It says that the uterus will be smaller than the cervix, which is distended. The internal os is not dilated, whereas the external os opens earlier than in spontaneous abortion, and the curettage of the endometrial cavity is non-productive of placental tissue. That is, there is no placental tissue in the curettage of the endometrial cavity. Lastly, coming to the combined extrauterine and intrauterine pregnancies, this is called as heterotrophic, ectopic pregnancy, in which an intrauterine pregnancy is associated with a tubal pregnancy. This is commonly seen after assisted reproductive techniques, and it is diagnosed by ultrasound, USG abdomen and pelvis. So here, after excision of the extrauterine pregnancy, in most cases the intrauterine pregnancy continues to grow without any complications. So this is all about the other ectopic pregnancies. Thank you.